Welcome everyone. I'm live at ComSciCon 2018, the Science Communication Convention in the Research Triangle Park of North Carolina. I have with me here Aaron Devanathan.
That's right.
Aaron Devanathan from UNC, fellow students at UNC. However, he is not in the pharmacology department, which is often confused with the pharmacy department. You are actually a pharmacy doctorate student. Is that correct?
Actually, no, I'm a pharmaceutical sciences PhD student.
Okay.
But I do have a PharmD.
Okay. You have a PharmD.
Right.
And you're doing pharmaceutical sciences PhD. So what is your research on and why do you like it so much?
Yeah, so the research I'm doing now, I'm working with Dr. Angela Kashuba in looking at HIV pharmacology. That's sort of a general term. But we're looking at specifically areas in the body in which HIV hides. Now, we know where they hide, but we're trying to figure out, do the drugs that we use for HIV, to treat HIV, do they get into those areas? And if so, how much? And how do they get in there? I don't want to get too much into the weeds, but the idea is that if we can figure out how these drugs get in there, because these particular areas are going to be sort of the barriers to a cure for HIV, if we can figure out if we can get drugs in there, then we could be one step closer to the cure.
Absolutely. Yeah. So I know the current state of HIV drugs is that I certainly treat a lot of it, right? And they're antiretrovirals, so they're not necessarily they're not killing the virus, they're not destroying it, but they're stopping its production.
Right, yeah. So we can stop the replication of the virus with these drugs in the blood. They do great work in the blood. But the question is, do they kill the virus in these reservoirs, is what they call them, the sort of the hiding spots. And so we know that drugs can get in there, but do they get there to an appreciable extent, to enough to actually kill the virus? And if they do, how can we determine which cells, have these, virus that's kind of in there, but sort of hiding and not really doing any replicating? So it's all very immunological in nature. But the idea is that if we can sort of figure out how we can get drugs into these areas, then we would be one step closer.
I've realized we missed a couple things. Aaron, thank you for coming on.
It's my pleasure.
Thank you for your patience. I had a lot going on today. Kind of a marathon day.
Oh, I'm sure.
And also, people might not all know what human immunodeficiency virus is or necessarily does. So it's known as the virus behind AIDS, autoimmune deficiency syndrome, right?
Exactly.
I haven't actually talked about that in a while, but so it was really big in the 80s. I know we were worried about the AIDS epidemic, and since it's not really made headlines, but it's still a problem, right?
Right, exactly. So 37 million people in the world right now live with HIV. There's about 1.2 million that lives in the United States. The UN AIDS in particular, which is sort of a global, sort of a WHO of HIV/AIDS, if you will, they estimate 1 to 2 million people per year will be newly infected with HIV. So you're right. In the 80s, it was an epidemic. And the reason was we didn't have any drugs for it. But right now, since 1987, that was the first drug that came out, zidovudine or AZT, came out, completely revolutionized it. And then more drugs came out in the early 90s, throughout the 90s, and certainly in the early 2000s. And I'm sure many of us have heard about the HIV cocktail. That's one where people would have to take mountains. Of course, that's I'm embellishing there, but they have to take a lot of drugs just to get to a point where they can get to a, quote, undetectable viral load. And so if you can get to that point, then you know that there's not HIV in the blood. But we've come a long way. So I always tell people who ask me about this, because it's always a good question, is, where have we come from? Like, what was it before? I would say just watch the Dallas Buyers Club. Not only is it a good movie, stars Matthew McConaughey, great actor, but he portrays someone who's very desperate for drugs at the time. Ron Woodruff, I think was his name, and then he, brought in HIV drugs illegally from Mexico and whatnot. But as we stand here today, we look at combination therapy in one pill, just one pill to take each day. Where it used to be, you'd have to take, 4 or 5, maybe even 6 pills a day just to get to where we are now, which is you only have to take one. And more drugs are coming out now. Just in the past 4 months, since the beginning of 2018, the FDA has approved 2 drugs for HIV, and one of them is a monoclonal antibody. That's essentially a type of drug that's used pretty much all the time in cancer. But since this is a very immune system heavy sort of virus, then, could we harness monoclonal antibodies? And apparently to the FDA, the answer is yes.
So an antibody is something that our body naturally produces, or it's a type of protein that our body can naturally produce. I guess why is adding extra antibodies? So the antibody way that works in the body, and correct me if I'm wrong, because I'm not an expert on this, especially with HIV, is it'll detect a piece of that viral protein and it'll latch onto it, and it'll allow the immune system to pick it up, clear it, and chew it up and destroy it much more effectively.
Right.
Now, adding antibodies to a system where the immune system is compromised, I'm a little confused on how that would help, right?
Yeah.
So if the immune system is already compromised and we're adding antibodies, can the immune system even know what to do with that, or it's in combination with the other drugs, like you said?
Right, yeah. So this particular drug, from what I understand, this was just very recent, so I haven't really read too much into it, but my understanding is that this particular drug is for very resistant HIV. Believe it or not, HIV can mutate, which really throws a whole wrench into everything. But this particular one targets a specific T cell in the body, the CD4 T cell, or a T helper cell, which is really at the cornerstone of a ton of different differentiation of T cells for the immune system, particularly to make antibodies. So, for all you people out there who know about the immune system, B cells, plasma B cells to make the antibodies and so forth. So the CD4 T cell is, of course, the T cell that is infected with HIV, or at least the one that people think about with HIV. So the antibody targets the receptor on that T cell. So as such, much like with cancer, sort of tumors produce some sort of receptor on them that allows these antibodies for cancer, for instance, to actually target that receptor.
Right.
It requires an understanding of the receptor in order to make the thing that can target the receptor. And so now we're at that point in HIV.
Okay. So you're basically manipulating all these little ID tags on different cell populations to do the work for you. And you brought up a good point about HIV resistance. That was going to be one of my other questions, in that bacteria are lately making the news for we're getting these super bugs, essentially. We're generating these from antibiotics, and you essentially use natural selection, or we're causing natural selection in these populations. We're killing all of the ones that aren't resistant, and then the resistant populations get so much stronger. Is the same thing happening in HIV? I haven't heard so much.
I would say it's similar. I think now, at least from what I've read, is that you have the ability to really tamp down HIV and its activity with daily drug. I think I read, I'm sure the statistic now just keeps getting higher, but you need about 90% per month to be able to do that. So if you kind of do the math there, you can afford to miss, certain days, but don't ever tell anyone that. You always say, just take the meds, and you can control at least the infection status. But yeah, mutation is always a problem. They have a database now that's done by Stanford, where clinicians can actually put in specific mutations, and then will spit out sort of a report as to what medications you should prescribe for a patient, for instance. So just have a good idea as to what you should do. So it's it's starting to get a lot more targeted medicine, and sort of a more global, personalized medicine approach.
Absolutely. So are there any, and maybe you don't know so much about this, are there any technologies going into like preventing early transmission of HIV, or is generally one of the reasons that we had less transmission because we had less viral load? Is that directly correlated, or is it possible that people still transmit the disease while they're on these medications?
Yeah, so it's still certainly possible to transmit this disease, because one of the things that is usually when it's transmitted through, say, sexual intercourse, it's always a question of, do these medicines get into, semen of males, or vaginal fluid of females, or rectal fluid for males and females? So these are, uncomfortable topics, of course, but, important topics, especially for individuals who are infected with HIV. I would say prevention purpose. The beauty of HIV is that, if you can call it a beauty, is that there's a lot of hard science that goes into it, which is sort of the work that we do in our lab. And then there's also the cultural aspect of it. So the societal impact of it, which is great. So if you can kind of merge the two together into one area, which HIV does, then you can kind of see how sort of the work you do can really have an impact on individuals. So a lot of the preventative focuses, should always be, prevention. So, the classic, use a condom, if you do engage in sexual intercourse with HIV and all that kind of stuff. So it's and needle sharing, of course. So these needle exchange programs has really cut down the rate, at least in this country. But there are, unfortunately, some areas in the world, specifically sub-Saharan Africa, that are still, afflicted with this.
is that probably the most afflicted and most vulnerable region right now?
Yeah, combined with political instability and geographical movement and so forth, and just the lack of resources.
Hard to get drugs there.
Exactly, and drugs are expensive, especially the newer drugs, which insurance companies here might be able to take care of, but can they really do that there? I don't know. It's a tough topic, but it's important.
Yeah, glad we have the brightest minds on it. All of that. So when we're talking about like the nitty gritty of your research, what are the changes that you're trying to make and the questions that you're trying to answer? How do you go about doing that? And maybe walk us through a day in the life of Aaron.
Yeah. So one of the things so our project is very big, which is nice. So I talked about how there are areas in which HIV hides. So a lot of these are very immune-heavy areas: lymph node, brain, spleen, and the gut as well. These are places that have a ton of immune cells all over. And so the idea is, does HIV get there? We know the answer to that is yes. Do drugs get there? For the brain, we have the most data because people are very interested in drugs getting into the brain, as I'm sure you would attest. But what about the spleen, for instance? That's the one that I'm working on, so I'm very attached to the spleen. But do drugs get in there? And so far, we work with analytical chemists to literally take spleen tissues from macaques who are infected with their version of HIV, which is called SHIV, or Simian Human Immuno-deficiency Virus. And we infect it with them. Not us, but I wouldn't want to do that. But we get the tissues back and we analyze the tissues for certain proteins that would be involved. So these are sort of drug transporter proteins that get drug in or pump drug out, and then kind of characterize that because it hasn't been done. So we figured, we'll take a look at it and then we'll see what we find out. So it's a huge project, but it's an important one. It's going to be something where people would have to take into consideration moving forward with development of drugs.
And so these new drugs, what is the biggest barrier, do you think? Maybe the liver, or it's just those tissues are actually resistant?
Yeah. So right now, if you want to completely cure someone of HIV, like completely eradicate it, you have to get into every single spot where HIV would hide. And that's pretty difficult, especially if you don't know if you can even get there. It would be like if you were to say, water the lawn, but make sure every single blade of grass is watered. It's like, okay, I can water the lawn pretty broadly, but can I truly ensure that every single blade is watered? Probably not. But we need to find a way to figure out how to get every single blade of grass watered. So what we'll do is at least have some sort of ability to check that out.
Are there any really bad side effects that say, all right, one strategy to watering the lawn is like, let's just douse everything. Right? Let's just completely soak it. I imagine you couldn't do that with a drug. Am I right? Or...
Yeah, it's kind of hard to do that since you're targeting a specific virus. So you're going to have to play by the rules that the virus plays with. So all the drugs really just focus on one aspect of HIV. But it's different. You're right. Because in cancer, back in the day, they, World War I experimented with nitrogen mustard gas. And some of the very, very, very old early editions that are not as used as much, actually harness the power of nitrogen mustard. Great to kill cells, great to kill cancer cells, but it killed everything. It's not exactly what you're trying to go for. So similar to oncology, where drugs are being incredibly more targeted based on mutation and tumor and location, all that stuff. Same thing with HIV. Same thing really infectious diseases as a whole.
So are there any myths about the HIV field that you want to dispel, like misunderstandings the public might have? Or it's not too much in the news, but I have heard like super AIDS. We were talking about HIV resistance. Yeah. Anything else that people just don't seem to really grasp the full understanding of? Yeah,
it's interesting. It's very you get a lot. I've been in the clinic, the infectious disease clinic at UNC, where we cared for a lot of people. We cared for a lot of people with HIV, and it's always, you always think, if you came in without knowing anything and you only just kind of listen to the news or anything like that, you would think that the most vulnerable people are those who are homosexual, usually homosexual men, IV drug users, or that's usually the big two. And those are indeed the case. You're absolutely right. Those are unfortunately the most vulnerable, and it's just unfortunate that's the case. But it's not just, those people. It can be quote unquote regular people. Usually it's unfortunately poorer people. And that happens to be the case. You see that a lot at UNC. But I think it's a huge public health issue, and I think we have a lot of good minds who are working on it. So I'm glad to at least be a little bit of a part of it.
Yeah, it's kind of one of my other questions I always like to ask is, what draws you to this as a research interest, and what is it about it that gets you kind of out of your bed in the morning and into the lab, and what's really driving you when you have like a bad experiment, as all the scientists have? You have a bad week, everything's failing. What keeps you going then?
No, that's good. It's a good question. So I mentioned earlier, it's the hard science and the cultural aspect of it, the societal aspect that really intersect at HIV, in my opinion. Oncology is the same way, of course. But what I like most about this, when I learned the drugs in pharmacy school, and there were at the time a lot of drugs that were used for HIV. There was just so many, but now they've really streamlined them. So that's not really a barrier to understanding it as much anymore. There's only a certain set of drugs that are used now, which is great. But my true interest into the research honestly came when I spent that month in the clinic and I actually talked to real people who are taking the real medications day to day. And I'm thinking to myself, even if you take it forever, you still don't eradicate it. So I'm thinking to myself, we've done a lot of great stuff. We've cured polio and, for some reason I can't think of really anything else, but we've cured a lot of stuff. And so I'm thinking to myself, what is it with HIV that's not? And I want to be a part of it because I think there's so much to learn about it. And there still is. I read about it almost every day. And I think every day, I read it every day. And there's everyone around the world, it's a very small area, which is nice. Small enough where people know, my PI knows so many people who know so many people. And it's just amazing how that sort of sense of community towards the goal of a cure and everyone's research interests are aligned towards that goal is, incredibly rare. And, I'm glad to be a part of it.
Do you have a lot of collaboration between other groups in the HIV field? I know, speaking from my own personal experience, the Alzheimer's disease field can be really spread apart, and we don't often talk to other labs about our research. I mean, we do, as much as we can, but some people seem a little maybe shy or off put by the reaching out. And then, especially in Alzheimer's, it was like kind of in a civil war for about half a decade ago. Yeah, there was some argument about what caused the disease, but I know in HIV, you guys are fairly united. You collaborate with other groups across the country, across the world?
That's right. Yeah, so our particular laboratory collaborates with a lot of different people, not only at UNC or Duke, but also at University of California, San Francisco, University of California, San Diego. I know we've collaborated with people in Malawi, in Durban, South Africa. So it's great. You can really interact with a lot of people across the world because it is a global epidemic. So a lot of people across the world are looking at it in particular. And UNC is a very big hub for HIV/AIDS research. The other one, in my opinion, is UCSF in San Francisco.
Okay.
So we're always pumping out a bunch of papers left and right, just coast to coast, really, and it's. It's great. It's great to meet these people. I have yet to go to a conference in HIV/AIDS in particular, but a big one called the Conference of Retroviruses and Opportunistic Infections, or CROI, because that's a heck of a lot easier to say. Just actually happened a couple weeks ago in March, and the work that people are doing there, I was just looking at their website, and it's amazing. And it's way over my head, that's for sure, but I hope to be there one day.
No, definitely. And I'm sure you will be. Speaking to the future of HIV, I know we as scientists need to be careful about overpromising and all of that. But we are actively looking for cures for these diseases, right? Realistically, and no one can fault you if you're wrong, because we are often wrong as scientists. Right. We try and be wrong as seldomly as possible. But realistically, when, if ever, do we find a cure for HIV? And then what do you think is like that major challenge? Maybe it was the analogy you gave earlier, but are there any other major challenges that we are going to have to overcome or advances in technology to get there? Yeah,
that is a very good question. So right now the key is to quantify the amount of HIV in these areas that I mentioned before. So there's a lot of different assays that can do that. It gets very difficult because you're targeting the drugs now can really take care of it in the blood, which is great. But And people who live with HIV, who take the drugs, can live as long as, someone like you and me who aren't infected with HIV. So that's good. We can at least, kind of pat ourselves on the back for that. But now it's the prevention. And can we really eradicate it? I'm very hopeful. So I want to say yes. Yes, we can. We can eradicate it. I don't think it's going to happen in the next 10, 15 years. I think a lot of the research is going into therapeutic antibodies, kind of what I mentioned before, which is not to get too in the weeds, but HIV kind of inhibits our ability to make antibodies towards HIV, and that kind of sucks because we do that great for when you get the flu vaccine. That's kind of what we bank on there. But can we have an HIV vaccine that sort of spurs the antibody formation against HIV? There's a lot of research that goes into that. I don't think it's quite there yet from what I've read, but I really do hope we can get a cure because I think it's time.
Yeah. Like you said, I think it has to be a combinatorial approach.
Right. Yeah.
Multifaceted. Sure. So how'd you get into this field first place, and what was kind of your path into science? You always know you want to be a scientist?
Yeah.
And inspiration.
So I always had kind of a clinical mind, which is why I went to pharmacy school, and we learned a ton of different drugs there and how they're used in the real world, and that's great. And one of the things that I caught myself doing was asking, well, why can't this occur? Why can't we cure HIV, for instance? And so when I first learned about HIV drugs in pharmacy school, that sort of piqued my interest in HIV and especially just ID in general. And so when I was in pharmacy school, I would always ask these types of questions. And, it wasn't until I actually came here and actually spoke with my current PI now on the phone. I told her, like, hey, this is sort of what I'm thinking. I really like HIV. I want to kind of explore this. And she had a fellowship at the time. And I was in my fourth year of pharmacy. I was in my fourth year of pharmacy school. And so afterwards, she said, I'm not taking anyone this year, which was 2016, which is when I graduated. But, do a year of residency and then come talk to me. So I actually came down here for UNC for pharmacy residency training, which is great. And then I talked to her again around almost a year later at that point. And then, I told her my goals, and she said, you should think about the PhD program here. I thought to myself, oh, goodness.
You're right after,
Just came out of pharmacy school, and I was like, oh, should I do more years of schooling?
Right.
And, I talked to a lot of people about this, even talked to my parents, and I said to them, like, hey, this is an idea. And my parents said, when do you want a real job? And so I talked to a lot of people, and, the goals and interests aligned. Then, she was taking graduate student, and, it all sort of worked out, and here I am now.
How would you compare and contrast like a PharmD versus a PhD pharmacy? It seems like to some people might think, okay, it's the same thing, right? But
one
in like daily life and overall like the goals of each degree.
So the PharmD trains you for a very clinical focus. So if you can imagine a pharmacist in a hospital or, Walgreens, something like that, where, these are people who are clinically trained. But that's really what the PharmD kind of trains you for. And so I kind of have that role, in me, I guess. The PhD, as I'm sure you would know, kind of trains you to be an independent researcher. So I guess one may argue, well, they both train you to be independent. That's exactly right. But the skills that you develop in PharmD, I think it's a little bit more team-based collaboration. Whereas in PhD, it's more, focus on the topic that you're studying, learn to become an expert on that, and then disseminate the research as you go. So honestly, I don't know how good of a scientist I would be had I not gone through PharmD training. I guess, it's sort of a moot point, but it's the end game is sort of different there. And so your skill set after you complete both degrees is going to be different.
Right. But you'll have both. So
I'll have both. So that's I think was it 9% or something like that. And this is as of 2014 of people with PharmDs have PhDs.
Wow.
So you can just sort of imagine the pool of people who have PhDs in general in the United States. Was that like 2% or something like that?
Not big, yeah.
So you can just imagine how narrow that pool becomes with a PharmD PhD. So,
So what do you have plans after that? Do you have a specific thing in mind, or?
I don't know. I've always thought myself in academia. I always like the aspect of running my own lab and kind of doing HIV research. But actually this particular conference in general, this ComSciCon, sort of opened my eyes to science communication. Science policy as well is something that I'm interested in. I'm a big foreign policy history buff. I won't bore you to death on that, but it's it's sort of open, I guess. And since I'm only a first year, I have the time to explore, which is nice, or at least have time to think about it.
Exactly. Yeah, you got a little time to figure out what you like and what you like. And it does seem like there are more and more options nowadays other than academia. That's really great. Like industry is blowing up, of course. Everyone's talking about that. And yeah, science policy has really been on the radar lately, especially myself. We just actually had an interview with Dr. Francis Colon, who was
I listened to that one actually.
Yeah, so it gives me a really good inspiration to think, okay, maybe there are other career options. And I would think in HIV especially, like knowing all the science behind HIV, you could probably make, or at least advise, some really great policy decisions. I think
so. I think just in general, just public health is one that I think overall has been getting pretty decent funding, or at least enough that I'm sure there are other areas that require more funding, and we should always fund, I think, public health. I think that's really just a benefit to everyone, really, and not just the beneficiaries. So I think, I'd like to try to explore that option, that career option as well.
For sure. Do you have any advice for people who are looking to either do a PharmD, do a pharmacy PhD, maybe some both? Is there... I know there's an MD, PhD for people who want to be a medical doctorate and also a doctor of philosophy, which is a PhD. Is there anything equivalent for like a PharmD, PhD, like joint program so you could get them both out of the way at once? Or
so interestingly enough, there are some programs in the country, including the University of Pittsburgh, which is where I got my PharmD. Got to put a plug in for there. They have kind of a PharmD, PhD program. It's not where you don't graduate with both per se, but you graduate with the PharmD first, and then you do a little bit of training afterwards, having done some of the classes towards PhD during your PharmD training. So you can kind of kill two birds with one stone with a little bit of overlap there. So specifically with PharmD, if you have an interest in clinicalness and chemistry, I think pharmacy is a very, very good balance of both. And what I really like actually is that you utilize principles of pharmacology. So as I'm sure, kind of relates to Cmax, trough levels, AUC, all that kind of stuff. That is language that is utilized in clinical settings, literally in clinical settings, trough levels. You measure that kind of stuff for a number of different drugs. And if you have an interest in that, the PharmD is the way to go. If you're interested in conducting research to be on sort of the back end of it, if you will, the basic science end. And of course, a PhD, specifically in pharmacology or pharmaceutical sciences, would be kind of your, your mainstay. If you're crazy like me and you want to do both, and you're doing it consecutively and not overlapping, there's going to be kind of a 4 plus however long the PhD is going to take. Then what I would recommend is, and you don't know you want to do the PhD after your PharmD, like myself. They just got to do some soul searching. But if you know early on, there are programs out there, very good programs that allow you to kind of balance both and sort of work towards both at the end of it.
Yeah, no, that's really neat that schools are paying attention. Realize some people do a little bit of everything. Yeah,
and MPH is a big one too. That's starting to get with the PharmD aspect. Yeah. So I know at Pitt, they sort of talked about getting an MPH.
Masters of Public Health.
Masters of Public Health, that's right, yeah. And same thing here at UNC. There's talk of, because public health is big, and pharmacists are readily available to provide that sort of work, which is great. Business is also another big one, the MBA. So there's a lot of opportunities out there with quote, just a PharmD, that you can do a lot of good stuff. And then I decided, I love school. Who needs money? So I'm going for the PhD.
Right, we don't need a real job. We'll just stay at school forever. It'll be fine. That's my life now, of course, a PhD student myself. But, it is really, the PhD is probably more for the very curious and very passionate, I would imagine. Just getting into the PharmD, though, chemistry background, it's probably the most important. Biochemistry, like if someone had to pick a major, let's say, like I'm coming out of high school, what would you advise?
It's funny you mentioned that because as you know, in ComSciCon, we have the option to write the paper or, write some sort of piece. And I actually wrote it on the importance of arts and humanities in these hard sciences.
Oh, cool.
So to answer your question, a lot of people do have science backgrounds, including myself. So I have one. My bachelor's is in pharmaceutical sciences. I got that from Pitt. So a lot of us had, biology, biochemistry, chemistry, something like that. Some of us even had engineering, which is cool. But there are a number of people who had degrees in the arts and humanities that come into it. So you see this really even in medical school, where they look at people who have degrees in, arts or, architecture or something like that. Nothing where you're thinking, well, how's that going to help you really?
like, how do you even get in? Right. How does that work? Yeah.
So I guess if you meet their prerequisites, they'll take a look at you. But I actually have a friend, Lauren. She has a background in art restoration and I'm gonna mistake this, and conservation. There we go. Art restoration and conservation. It was kind of a makeshift sort of degree for her, which is great. And I actually talked to her recently. She's a pharmacist at UNC Hospital, and I talked to her. I said, "Look, your background has nothing to do with pharmacy. Like, how in the world is that really helping you?" And I asked her that in kind of a glib fashion, but she answered in a very amazing way, which is, in this particular, and I know nothing about art, by the way, art, conservation, and restoration.
So do I, yeah.
You look at things globally, and then you look at things on a very minute level, which is exactly how pharmacists sort of operate. They look at the patient as a whole, but then when they kind of have to dig into one particular area of focus, they really, really dig in. And so they read, pharmacists read a lot, and, PhD students read a lot too. And so when I talked to her about this, it was, I thought, I wonder how other areas can do that. Could arts and humanities be useful in other hard sciences? So even if you ask, so I read this book actually called, not to get too off topic here, but In Defense of a Liberal Education by Fareed Zakaria.
I've heard about that. Never actually. Oh, yeah.
It's a great book. This is a guy who knows so much about foreign policy, worked for Newsweek, has his own show on CNN. So I feel like if you have your own show on CNN, you're doing something right.
He's done well, yeah.
Exactly. He's well versed. He's written, I want to say, a gazillion, you can quote me on that, books on foreign policy. And he wrote one on this. He has a background in government, I believe, from, I think it was Yale, and then got his PhD from Harvard, a small school in Massachusetts. And
heard of it, I think.
And he wrote this book saying, look, STEM is great. And I'm not saying destroy STEM or anything, but arts and humanities can help you out. Critical thinking, learning how to speak and write. This is the type of stuff that aren't necessarily the focus of STEM.
Yep.
But they are in the arts and humanities. And so you can bring that into the STEM and make you a better overall STEM whatever you're doing. So that's why I think communication in particular, I may not base a career on it, for instance, but hey, it can make me a better scientist.
Yeah, absolutely. I found just thinking about my science in ways that I know my mom or my grandmother will understand it.
Right.
It actually makes it simpler for me, so I might notice a connection I never noticed before, right? Exactly. If I'm actually drawing this analogy, I'm like, oh, wait, you know what? It really is like that. Maybe I can add this experiment in to test if this side thing is happening, for example.
Right.
Anyways, tangential. But I think perspective is important. Absolutely.
Yeah.
And I'm sure that helps you between the PharmD and the PhD research. Probably getting a little bit of perspective that way too.
That's right. Yeah. So that's one of the things that UNC and Pitt and Kentucky and Minnesota, these are, and UCSF, I've got to throw that in there too. They really focus on, if you're going to do pharmaceutical sciences and you have a PharmD, for instance, or a clinical background in general, usually it's PharmD just because, it's in the pharmacy school and people are used to that. You can bring a lot of perspective. A lot of it comes from feasibility of research. I know if you try to write a grant, one of the key things is going to be feasibility. And if the research is super, super awesome, but honestly, you're not going to be able to draw blood, for instance, like 100 times a day. Like, that's just not going to happen. But to have some sort of clinical background, I think, has given me a lot of perspective, specifically in HIV, just because that's the focus. So it's interesting how people with different backgrounds can actually come together to do something. Just like art restoration and conservation. Like, doesn't have anything to do with pharmacy, but hey, he's probably one of the smartest people I know, so there's that.
It works, absolutely. Well, thank you so much for coming on, Aaron. It's really been a pleasure.
Thank you for
having me. Are there any last things you want to say to people about HIV, the future of it, or anyone looking to get into the field again? Or do you have any social media accounts? Where can we reach you if we got questions?
Yeah, so I am on LinkedIn. I don't have Twitter because I'm not that active on social media, to be perfectly honest.
I can't keep track of them all.
But I know our particular lab has social media. It has a Twitter, which the handle, I think, is at Kashuba Laboratory, at Kashuba Lab. So there is that.
We'll post a link if you can.
I'll send it to you.
We'll put it up in the show notes. People can find it below. Yeah.
And we also have a Facebook page, which right now is just kind of graduate student alumni and people who are involved in the lab. But we're trying to expand. And I think one of the key things is getting our work out there to the public and just kind of seeing what happens. So I'm excited.
Yeah, we'll hopefully throw some questions your way from people who listen to the episode and be expecting them, I guess. If you want to, once you publish, I know there's a kind of a longer process for this in defense of arts and humanities in STEM article you're writing. Once that's published, let us know, and we'll toss that show notes below. So if for those listening, check below if you're interested in that article. Hopefully it's up by then.
Perfect. Great. Thank you so much, Connor.
Yeah. Thanks for coming on, Aaron. Thanks for listening, all.